Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hello, everybody. Thank you for the warm welcome back. I am graduating this afternoon, and so I think this is one of the last times I'll be introduced as a fellow, which is crazy, and I'll be joining faculty in a couple months. And so I just feel very lucky today. I decided to do the second presentation in this series on my favorite because I think it is central to the work that we do. I think if you drew a Venn diagram between geriatricians and ID providers, the middle chunk would be all of the things that makes medicine really special. Individualized care, patient-centered care, being really mindful of our language and implementing harm reduction on the go. And so I really don't think I'll be teaching anything new to you today because I know that you're all doing these things, but I'm hoping that I can introduce maybe a new framework for the way a lot of geriatricians are starting to put this patient-centered, value-based care into practice. As usual, I have no conflicts of interest. This is a slide that I put at the beginning of every presentation I've given this year, just to highlight for anybody who's unaware that this is an incredible time for me to be entering this field, because this is a huge population of people who are aging with HIV, and their needs are quite unique. And so it is an exciting time to be providing care for them. In 2017, the John A. Hartford Foundation developed this model called age-friendly care to address the care of older adults nationwide, because they recognize that older adults face a disproportionate amount of harm in healthcare settings, in hospital delirium, polypharmacy, inadequate goals of care discussion. And so they created the 4M's model, which is on the left. And at first glance, it is deceptively simple. We are talking to patients about their mobility, how they navigate the world, the way that they think about the world, mentation, which can encompass things like delirium in the hospital or out of the hospital, depression, which can impact their ability to think clearly, and then, of course, the incidence of dementia, which increases with age. We have to be more mindful of the way that we're prescribing medication, because obviously mentation, mobility impact the way that we can take medication, but also our metabolism changes and people tend to fall into the prescribing cascade as they get older. And then at the very tip top is what matters to the patient, and that we hope that the things that we are discussing and documenting and prescribing and recommending are all in service of what matters to the patient and not necessarily what matters most to us. So if you're familiar with Madison Clinic, this is a draft of the dot phrase that I have stolen wholesale from Senior Care Clinic, with some tweaks to illustrate what I'm asking providers to talk about with their patients, for those who are a little bit less familiar with geriatric review of symptoms. And so today we'll talk specifically about the what matters. And again, I know you're already doing this. The harm reduction I see every day at Madison Clinic warms my heart. And so here's hopefully a new framework. Very quickly, we know that age-friendly matters, and we see that this is probably an outdated figure now, I believe this is from 2022, and we see that more and more sites are being recognized as age-friendly, and I'm in the process of making Madison Clinic recognized as age-friendly from the folks that started this initiative. Before I dive into the what matters, I just wanted to highlight that we know that this works. There's been lots and lots of studies that show that this improves patient care in all the ways that matter to the hospital. Decreased length of stay, patients are happier because we are more explicitly catering to what matters to them and their individual circumstances. You've stepped foot in emergency rooms like Harborviews, and we know that the less time people can spend in there at all ages, but especially older ages, the better. Improving delirium outcomes and reducing incidence is both incredibly life-saving for the patient, but also much cheaper for the hospital, and not on the slide, but decreases our discomfort also. Okay, so I wonder if patient priority care, that title, is new to this group. And I kind of hope it is, because that's what I'm going to talk about for the next 20-something minutes. And this is a way to highlight patient-centered values, goals, and preferences in our care on a daily basis. Patient priorities care is a model that was developed by VA providers, since VAs typically have a large number of older adults aging with a variety of medical conditions. And so the way that this works is we take what matters most in the 4M's model. And we tie that directly to actionable, specific, realistic healthcare goals and outcomes, and asking patients what is the one thing they want to address, and then making sure that the language I use is highlighting to the patient that what I am doing and recommending is indeed the thing that they want to address. And so we'll talk about that in more granular detail. To start with some definitions that seem very obvious, and then I hope it'll become clear why I'm spending some time talking about it. We talk about value-based care and patient values all the time, and in this patient priorities care model, values are states of meaning. They are subjective and personally chosen, and these are typically unchanged throughout a patient's lifespan. They are central to one's identity. They are large, overarching direction for one's life. And so examples that may come up are, it is important for me to be a loving family member or grandparent, or the most important thing for me is maintaining my role in the community and to maintain my friendships, even as we are all evolving and growing and changing. And this is compared to goals, which are actions or behaviors that are more specific, and these are more likely to change more rapidly. They change with clinical trajectory. And then we can use patient ranked priorities to rank these goals and hopefully bring the values to life. And so I hope you can see the difference between it's important for me to be a loving grandparent with the very specific and right now goal of I want to be able to walk the 6 blocks so I can take my granddaughter to school each morning. Or I want to get stronger with physical therapy so that I can go on walks with my friends again, because that is very core to the way that I maintain my friendships. And so here are some examples of core values. And I really love this model because sometimes I think those of us who have been in like academia and the sciences for so long struggle to describe these things that patients are telling us. And so I wonder if you could humor me and take a minute, and this is very personal, so I don't expect you to put it in the chat or unmute yourself, although if you would like to, that would be nice. And think about values that are core to who you are, that have been present with you since you were a child, now as an adult, and are likely to stay true to you as a person as we all age. And then think about some goals that illustrate that value for yourself that are true to the moment right now. I prepared one to tell you to share a little bit about myself, but instead I got injured last week, so I have a new example. I got injured playing volleyball and hurt my knee. And so my values, it's very important for me to stay active. It helps with my mental health. And so my very specific time goal right now is to re-engage in physical therapy so that I can get back to playing sports and spending time with people who aren't in medicine. No offense to you all. And I wonder, as you're thinking about those things, whether any of these rose to the surface and whether you can think of patients that have really illustrated some of these things for us. I know that just in this week, I've met patients who have really blown me away with their creativity and their patience with their own family circumstances. I know dignity comes up a lot, especially in the hospital, where we strip it away willy-nilly from people, and the ways that we can illustrate and honor these values in the patients that we take care of. And so when we apply these, that model works across the lifespan. And then as we zoom into older adults, we'd like to focus on the 4 domains that really matter as we age. And that is maintaining connection, and know that social isolation is a huge problem for older adults, and particularly for older adults with HIV. It goes without saying, we'd all like our older adults to actually enjoy life and find some joy and humor. We wonder how they're managing their health so that they continue doing the things that matter to them, and then specifically what their functional status is. And as we zone in on these 4 domains, we're going to move from general to more specific questions, and I hope to illustrate that in a second. Domain 1 of connecting to people around you. I hope that these next few slides are helpful, because as we're thinking about these kind of very philosophical questions, I sometimes like just to have stock questions I can pull out if I'm feeling otherwise overwhelmed or having a difficult time connecting to somebody. And it makes me feel like I'm not applying my own bias if I'm using kind of standard questions to everybody I'm taking care of. And so starting out broad, who are the people in your life? Who is your tribe? Who is your support system? And how often do you get to see them? I really love asking, what are the events, meetings, and celebrations that you attend in your community? Is there a summer barbecue that you are really looking forward to attending, but perhaps there's something getting in the way of you being able to do that. And then I think something that we need to think really critically about, particularly in the patients aging with HIV population, is how much are our patients sharing with their families and their communities about their individual healthcare needs and goals. Domain 2 is enjoying life. I love talking to people about what they do for fun. A couple of weeks ago, a patient was kind of reluctant to engage with me about these questions. He thought I was being distracted and not talking about the medical things. And I was trying to illustrate for he and his sister that were in the room with me that the reason I'm asking these questions is to make sure that I'm tailoring his care to the things that actually matter to him. And I started listing hobbies that I know people in this area do. And when I mentioned pickleball, because I do love to play pickleball, his sister gasped and rummaged in her bag and pulled out her pickleball racket. And it was the first time that I saw my patient, who had had very little patience with me up until that time, crack a smile and laugh at his sister. So that will live in my head as a really charming moment. And the reason, again, we're asking these is what kind of health problems do you have that make it hard for you to enjoy your favorite activities? What kinds of things are so crucial to you that you really just can't imagine life without them? And then in palliative care, they ask a lot about what typical days look like. What is the best day you've had? And what are the bad days? What kind of days are you usually having? I think something that we take for granted as healthcare providers is the amount of touches that most of our patients are having with the healthcare system. And so asking people what their perspective on things is really helpful. For those of you who do Medicare annual wellness visits, there's a standardized question in there about how they self-report their health from poor to very good on a scale of 5, I believe. The pictures I chose on this slide are things that we are frequently sending our patients to interact with the healthcare setting. And you can imagine if someone's on dialysis and they're needing imaging and frequent labs and they're in physical therapy because you don't want them to fall, this is occupying a huge, huge chunk of their time. And then finally, tying it all together is their ability to function, asking patients, what kinds of things are you able to do to take care of yourself? And I like this framing because it's a little bit more strength-based than what kinds of things are you needing more help with, which shies a little bit more towards the negative version of that statement. There was a really cool poster at American Geriatric Society or AGS conference this year about asking veterans how they feel about asking for and accepting help. And it really highlighted how much stigma there is for people accepting help as they age, even if it may allow them to do the things that they want to do. And then the blue at the bottom of the slide are questions that are helpful if there's a medical decision to be made. If you're at a crossroads, say if someone's been recently diagnosed with a life-threatening illness or a cancer, and asking if they've given any thought to medical interventions they'd like to avoid. The other time I bring this question up is if one of my patient's spouses or otherwise another family member recently went through a really hard thing, and asking them how they felt about those things. And sometimes you learn a lot about their impression from that by proxy. The final bullet point is what palliative care doctors refer to as a trade-off statement. So what kinds of things would you be willing to trade if it gave you the possibility of a little bit more time? And here's the meat of it. You spent the first part of the discussion eliciting values and what kinds of things highlight this person's personhood and makes life worth living for them. And then you are trying to connect that to a healthcare goal that they may or may not be reluctant to engage in. And so statements I use all the time, I'm hearing that value, whatever it is really important to you. Dignity, independence, spontaneity is really important to you. And making sure that I am truly getting that right from what they're saying, because there is an inference to be made there. So I'm often asking patients that I get that right. If there is a symptom that is preventing them from getting out there and playing pickleball, say a knee injury, hypothetically speaking, kind of highlighting that and showing that you're listening, and then using that to tie what intervention would be closer to getting to their goal. And so I know that you're all doing this. Again, this is the way that we doctors think about like getting from point A to point B, but I like this language a lot that was developed by this model so that what we know in our heads is being explicitly highlighted for the people in front of us. If you get stuck in these discussions and the thing that you are recommending to bring somebody from point A to point B in order to highlight their value, here are 5 strategies. So one is wondering, is there a gap in your explanation for why X intervention would get them from point A to point B. And so exploring what's giving you pause. It sounds like even though you want this thing, the intervention that may get you there is giving you some pause. And then perhaps the thing that you're recommending is really scary. And so wondering if we can make it easier or less bothersome. Would physical therapy in your home be less scary than going to another facility and adding another appointment to your life? It's generally good to be gentle with educating. I find that it's not usually a knowledge gap, but say that there is. And so one common example is patients attributing a side effect of the condition to a medication, and then they're reluctant to keep taking that medication. And so rather than saying, no, you're wrong, you can sidestep that and say, there's probably some other reasons that might be causing the symptom. Is it okay if we discuss some of those possibilities? Be flexible. It's possible that their goal is really admirable, but may not be feasible in the time that they are wishing for it. And so brainstorming other ways that we can continue to highlight their value that is central to their personhood. As they age and future events may become more or less likely, making sure that you're framing possible adverse events or side effects of either aging itself or one of their health conditions to highlighting that the goal that they want. And so I understand it's really meaningful for you to be able to walk your granddaughter to school every day. I'm really afraid that having a stroke or having heart disease would interfere with your ability to do that. And so making sure that is you're highlighting their goal before you start talking about the scary medical things. And then really, I wish when I'd made this slide, I'd put this one before educate, because again, when you're bringing up scary medicalized things, it's just not like a knowledge gap. And so I would encourage you, if you're getting like hackles raised, that it's probably not that they are disagreeing with you based on content, but that there's a lot of emotions coming up. And so I imagine the concept of a nurse statement is not new to a lot of people in this room, but making sure that you're respecting the emotion that may be coming up, because if someone is blindsided by a lot of anxiety or grief or frustration about everything they've been through so far, they're not in a place to listen to you continue to explain a medical rationale quite yet. I'm asking you to put more on your to-do list when you already have very busy clinic visits. And so I'm sure you're asking yourself, when should I be having these conversations? And there's no wrong answer to this, but I would prime you to really set some time aside if you have patients who have a serious medical condition. I'm leaving that vague on purpose. If there's an upcoming procedure or surgery that may interfere with their goals, and making sure that they have some time to, in a safe space, to vent about how devastating this might be on their life. If they've just come out of a hospitalization, and giving them time to talk to you about how that went. Honestly, if a patient brings this up, which as they age, I feel like people are thinking about it and talking about it, and this may come up from them. If there's an upcoming transition in care, so like if they're moving from their own apartment where they've lived for many, many years to somewhere where they have more assistance, this might be a good time to talk about it. And then if you're going to consult palliative care, with all the stigma that palliative care can carry, especially in this population, it's usually helpful if we set the stage for some of the basic conversations before introducing a new stranger, especially since you all have fantastic rapport with your patients. Usually when I tell, especially trainees, that we're going to talk about goals of care, the thing that people assume I'm talking about often is code status, and code status is such a teeny tiny part of this. But if the moment feels right, or you think this is something that is likely to become relevant prior to a surgery or a hospitalization or prior to a serious medical treatment course, I would urge you to be as specific as you can. When you talk about heart stopping and CPR, people think about movies, and we all know it's not like that. And so trying to frame the most likely decompensation for that particular patient. Some obvious examples are if a patient has like advanced COPD, explaining the context in the context of their COPD, as opposed to more philosophical or hypothetical statements. And then when you've learned all about their values and goals, rather than asking how they feel about this, I urge you to feel confident in giving a recommendation based on your desire to be as independent as you can. I wonder if not requesting CPR or resuscitation would be the most in line with the things that are important to you. Of course, before any of these serious conversations, you ought to be asking permission. I've been racking my brain to try to remember the name of this gentleman from UCSF who tweeted back when we used Twitter more, a fantastic analogy for this. And forgive me if this is already familiar to the audience, but his Twitter thread was about most of us walking into a computer store and a computer expert asking us what we want in a computer and listing out a bunch of memory and processing, I don't even know the words for this, things. And most of us, I think, would stare at him blankly. But if they asked us, what do you use your computer for? The store person would be more likely to help us if they gave us a specific recommendation based on our values and goals for using a computer. And I really like that metaphor, because if you asked me about computer things, I wouldn't know. And I imagine that's very similar to most people walking into a hospital. I have spent this year deep in the weeds, thinking a lot about language and the way that we can make these serious, big discussions less scary for our patients. And this is a handful of the people who've given me a lot of time and space to think and practice. And so thank you to these mentors.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.